Welcome back to the deep dive. Okay, let's jump right in. Today we're looking at something really critical, something that demands quick thinking.
Yeah.
We're doing a deep dive into status epilepticus.
And we've got a great resource to guide us today. It's a set of revision notes that you, the listener, shared with us specifically on status epilepticus.
Exactly. So our plan is to unpack these notes together, point out the absolute must-knows, the high-yield stuff for your revision, turning notes into real understanding.
That's the goal, making this complex topic clear and memorable. So where do we start? The definition, I suppose. You said it's a medical emergency. Why is that?
It absolutely is. And the definition in your notes is key because it tells you when it becomes an emergency. It's basically prolonged or recurrent seizures.
Right, but what counts as prolonged?
Good question. The magic number, according to these notes, is over 5 minutes of continuous seizure activity. Or if someone has multiple seizures, like 2 or more within 5 minutes, but crucially without regaining consciousness between them.
Ah, okay, so that 5-minute threshold, that's the real decision point, isn't it?
It really is.
Yeah.
And it's not just an arbitrary number. It's picked because after that point, the risk of, well, actual brain damage starts to climb significantly. The whole urgency is about stopping it before that happens.
Makes sense.
Your notes also highlight 2 main types. Convulsive status epilepticus, that's the classic one most people picture, with the obvious shaking and jerking, the big emergency. And then there's non-convulsive status epilepticus. Still very serious, but it can look different, maybe more like confusion or altered mental state, without the dramatic movements. Easier to miss, potentially.
Yeah, that subtlety is important to be aware of, definitely. Okay, so moving on to the why, what actually causes status epilepticus? What are the etiologies listed in the notes?
Right, the causes. The notes give a pretty thorough list. Often the starting point is someone who already has epilepsy or a known seizure disorder.
Okay, that makes sense.
But a really high yield point, something your notes really stress, is medication issues. Specifically, non-compliance. Maybe someone stops taking their anti-epileptic drugs or withdraws from them too quickly. That's a big trigger.
So it's not just having epilepsy, but how it's managed or not managed sometimes.
Exactly right. Then you've got acute problems affecting the brain directly. Things like infections, encephalitis, meningitis, or head injuries, strokes, even brain tumors.
Right, direct insults.
Yeah. And metabolic issues are critical to check, too. Things like severe low blood sugar, hypoglycaemia, or major electrolyte imbalances. These can definitely trigger status.
Okay, what else?
And then substances. Drug intoxication or overdose is on the list.
Sure.
And alcohol withdrawal. That's a particularly common and dangerous one. And finally, some underlying genetic conditions can predispose people.
That's quite a range of possibilities. So building on that, who's more likely to experience this? What about risk factors? Is there much overlap with the causes?
There's definitely a lot of overlap, which kind of helps reinforce the key points.
Yeah.
A history of epilepsy or seizures is obviously a major risk factor.
Naturally.
And medication issues pop up again. Non-compliance, yes, but also recent changes in medication. Your notes really hammer home how vital consistent treatment is. Substance abuse is another clear risk. And those existing brain problems we mentioned, infections, injuries, stroke, tumors, they all increase risk too.
Are there any other, maybe less obvious risk factors mentioned?
Yes, the notes point out age. Both the very young, so under 5s, and the elderly, those over 65, seem to be at higher risk.
Interesting.
Genetic predisposition comes up again, intellectual disability is mentioned, and having any kind of structural abnormality in the brain. The notes also do a good job distinguishing potential triggers, the things that might push someone already at risk over the edge. These include, again, drug withdrawal, getting acutely ill with something else like an infection, those metabolic disturbances we talked about, small strokes or TIAs, and alcohol intoxication or withdrawal. It helps connect the dots, underlying risk plus an acute trigger.
That distinction between underlying risk and the immediate trigger, yeah, that really clarifies the situation you might face. So once it starts, what's actually going on in the brain, this sustained electrical storm,
Right.
the pathophysiology.
Yeah, what's happening inside. Fundamentally, the brain's normal stop mechanisms for seizures just aren't working. The excitatory signals keep firing like a switch is stuck on full power.
That the engine's just constantly redlining, no break.
Exactly like that. And that has huge metabolic consequences. The neurons are working overtime, burning through energy like crazy. This excessive firing also leads to something called excitotoxicity. That's a key term from the notes. Basically, neurotransmitters like glutamate get released in massive amounts, overstimulating neurons to the point where they actually get damaged.
Oh, ouch.
Yeah, it creates these major neurotransmitter imbalances.
Yeah.
And all the sustained stress, the overstimulation, the metabolic chaos, it ultimately causes neuronal damage and, well, cell death. That's the core reason for the urgency we keep talking about. You're trying to stop that damage becoming permanent.
That really brings it back to that 5-minute definition and the risk of irreversible harm. Very clear.
Right.
Okay, now, differential diagnosis. If someone presents with something that looks like status epilepticus, what else could it be? Why is it important to rule other things out?
Super important because getting the diagnosis wrong means delaying the right treatment. Your notes list several mimics. Complex migraines, for instance, can sometimes have weird neurological symptoms. Metabolic encephalopathies. We mentioned these as causes and risk factors like severe low blood sugar or electrolyte chaos. They can cause altered consciousness or seizure-like activity. So definitely need checking quickly. Drug intoxication and other overlap can cause movements that look like seizures.
And what about the one that often causes confusion?
Ah, yes. Psychogenic non-epileptic seizures, PNES. This is a big one. The fascinating thing here, as your notes point out, is that while they might look very similar externally, sometimes even like tonic-clonic seizures, they are not caused by abnormal brain electrical activity.
So it's a different mechanism entirely.
Completely different, psychologically driven. Your notes specifically mention distinguishing true tonic-clonic status from pseudostatus epilepticus, which is another name for PNES. It's crucial.
I see.
Other neurological emergencies are also on the differential list, things like stroke, brain bleeds, serious infections. Notice how many of the actual causes of status can also mimic it initially. Underscores why a thorough workup is needed.
It really does. Speed and accuracy are key. Okay, let's touch on numbers briefly. How common is this condition? What do the notes say about epidemiology?
Yeah, the notes give some global figures, as specific UK-wide stats aren't readily available, apparently.
Yeah.
Globally, it's estimated somewhere around 18 to 23 cases per 100,000 people each year.
Okay.
Though the overall recorded range is wider, like 3.5 up to maybe 50 cases per 100,000 person years. It really can affect anyone, any age group. But linking back to risk factors, the notes do reiterate a higher incidence in lower socioeconomic groups, and definitely in those age extremes, again, under 5s and over 65s.
So maybe not an everyday event for every clinician, but frequent enough that you absolutely must be prepared for it.
Right.
So what does it actually look like clinically? What are the key signs?
Well, the most obvious sign, especially in the convulsive type, is just that the prolonged or repeating seizures, like the definition says, repetitive jerking, generalized convulsions.
Right, the classic picture.
Yeah. Usually accompanied by loss of consciousness or at least significant altered mental state confusion, not responding. Your notes list some specific things to look for, too. Tongue biting, maybe drooling, incontinence urinary or bowel,
Okay.
and also signs of breathing difficulty. That's a really critical point because it links directly to complications and the immediate ABC management.
And is it always that dramatic convulsive picture?
Not always.
Yeah.
Like we mentioned with non-convulsive status, the signs can really vary. It might be much more subtle, maybe just staring blankly, slight twitching, or just being profoundly confused and unresponsive.
Right.
And again, that distinction from pseudostatus, from PNES, is relevant here. The movements might look similar sometimes, but the overall clinical context and history are vital.
Okay, so you suspect it based on these signs. How do you confirm it? And really importantly, figure out the why. What investigations are essential?
The investigations have two main jobs. One, confirm there's ongoing epileptic electrical activity, and two, find the underlying cause. For confirming the activity, the gold standard is the EEG, the electroencephalogram. That records the brain's electrical signals.
The EEG, right? And for the cause?
For the cause, you absolutely need blood tests. Stat.
Yeah.
Check those metabolic things, electrolytes, glucose. Remember how often low blood sugar came up?
Yeah, definitely.
Bloods also check for infection markers. Then brain imaging, usually a CT scan initially in the emergency setting, maybe an MRI later looking for structural issues like strokes, bleeds, tumors, injuries. And if you're worried about an infection like meningitis or encephalitis, a lumbar puncture, a spinal tap is needed to check the cerebroprospinal fluid. Your notes mention other tests might be needed too, depending on what you suspect clinically. Okay, comprehensive workup needed quickly. Right, we've covered the what, why, who, what it looks like, and how to investigate. Now the crucial part, management. How do you stop this thing? Yes, this is probably the most vital section for revision. It's all about a rapid, structured approach. The goals, as your notes lay out, are clear. Stop the seizure ASAP, keep the patient safe, and find and treat the cause. It's stepwise.
Stepwise. Okay. Let's walk through it. Starting outside the hospital, in the community.
Right, pre-hospital. First thing, safety. Protect them from hitting things, injuring themselves. Then basic life support check, airway, breathing, circulation. The ABCs.
Always the ABCs.
Always. If a seizure goes past that 5-minute mark, or it's clearly prolonged for that person, and if rescue medication is available and prescribed, the first salon drug your notes mention for community use is buccal midazolam.
Buccal midazolam, key one to remember.
Absolutely. Put it between the gum and cheek. Rectal diazepam is noted as an alternative if needed. If somehow IV access is available pre-hospital, maybe by paramedics, then IV lorazepam is an option. And obviously call for an ambulance if seizures continue or you have any concerns at all. Get them to hospital.
So buccal midazolam is the main community tool. What happens when they arrive at A&E?
Okay, hospital management. Again, reinforce the ABCs, secure the airway if needed, give high concentration oxygen, quick reassessment of heart and breathing, and critically, check blood glucose again right away.
Don't miss hypoglycaemia.
Exactly. Easily fixed if that's the cause. The first line IV medication in hospital is IV lorazepam. That's the go-to. Alternatives listed are IV diazepam, or even buccal midazolam again, if getting IV access is proving tricky.
Okay, first line IV lorazepam. What if that doesn't work, if the seizure continues?
Then you escalate. That's the stepwise part. If first-line benzos don't stop it after adequate doses, you move to second-line agents. Your notes list IV phenobarbital or IV phenytoin.
Phenobarbital or phenytoin? Okay.
Now, if you're dealing with refractory status epilepticus, meaning it's still going despite first and second-line drugs, then you need the heavy hitters. Continuous infusions. The notes mention IV midazolam, propofol, or thiopentyl sodium.
Wow, those are serious meds.
They are. And what's interesting is your notes state that these refractory cases might actually need general anesthesia to get control, basically putting the brain activity right down.
That escalating structure really shows the severity.
It does. And while you're doing all this, giving the meds, you're also running those emergency investigations we talked about, bloods, imaging, and actively treating any underlying cause you find, like giving glucose if they're hypoglycemic.
Right, treating the cause simultaneously. And after the seizure finally stops, what's the ongoing management?
Yeah, the work isn't over. The next priority is confirming and treating that underlying cause, properly managing the infection, controlling the blood sugar long-term, dealing with withdrawal safely. You also have to watch for and manage any complications from the status itself for the treatments. For people with known epilepsy, you make sure they're back on their regular anti-epileptic drugs, probably checking levels and optimizing doses. If someone has recurrent status, they need a clear, individualized plan.
And what about prescribing rescue meds for home use?
Yes, your notes make a specific point here. Buccal midazolam, or rectal diazepam, for community use should only be prescribed for patients with a documented history of prolonged or serial seizures, not just for anyone with epilepsy.
Got it. Specific indication.
Yeah. And the notes also mention ongoing monitoring, like checking drug levels, and the need for critical care support, especially for those really difficult refractory cases.
It's a whole pathway, isn't it? Much more than just the initial emergency. Okay, finally, looking ahead. What's the prognosis usually like after status epilepticus, and what are the potential lasting complications?
Prognosis. Well, it varies a lot. Depends heavily on the cause, the patient's age, their baseline health, and this is key how quickly treatment was started. Your notes really emphasize prompt intervention improves prognosis. Big takeaway there.
Okay. Any numbers on outcomes?
Short-term mortality rates are quite variable, maybe 0.5%, in some groups up to 20% or even higher, especially in older adults like over 65s.
Is there any way to predict how someone might do?
Yes. The notes mention something called the STESS score, Status Epilepticus Severity Score. It's a tool used at presentation to help predict prognosis based on age, level of consciousness, seizure type, and whether they've had seizures before.
STESS score. Useful. What factors point towards a worse prognosis?
According to the notes, older age, lower level of consciousness when they arrive, and interestingly, both convulsive and non-convulsive types are listed as potentially worse prognosis factors, which highlights that non-convulsive isn't benign.
Right.
And also, perhaps counterintuitively, having no prior history of seizures can sometimes mean a worse prognosis, possibly because it suggests a really severe new underlying cause.
That makes sense. Is prevention possible at all?
For people with known epilepsy, yes, the notes suggest prevention is partly possible. Good control of their baseline seizures through sticking rigidly to their medication plan, lifestyle factors, regular medical follow-up, all listed as preventive.
So controlling the everyday seizures helps prevent this major escalation.
Seems so. Your notes definitely state that good seizure control is preventive.
Yeah. Okay. And the complications. We touched on brain damage during pathophysiology. What else is listed?
Yeah, the complications are basically the fallout from that intense, prolonged brain activity and the stress on the body.
Yeah.
Brain damage is top of the list. Potential cognitive problems, memory issues, neurological deficits. That links right back to excitotoxicity and why stopping it fast is crucial. Respiratory problems are common too. Breathing can be impaired during status, leading to low oxygen, hypoventilation, even respiratory failure. Connects back to the clinical signs and needing oxygen and airway support.
Right. Systemic effect.
Yeah, serious cardiac issues like arrhythmias, even cardiac arrest, and systemic problems affecting the whole body. Hyperthermia, the body getting too hot,
Yeah.
metabolic acidosis, acid building up. It shows it's not just a brain issue, it affects everything.
Wow.
The notes reiterate long-term neurological deficits and cognitive impairment as potential outcomes, and sadly, mortality risk is a significant complication, especially for the elderly or those with serious underlying conditions.
It really paints a picture of a cascade affecting the entire system, which leads to a final thought, perhaps.
Go on.
Well, looking at everything we've discussed from your notes, the causes, the mechanisms, the presentation, the treatments, the outcomes, it's all so interconnected, isn't it?
Definitely.
So thinking about that STES score and the prognosis factors we just mentioned, maybe a point to consider is, how does that very initial clinical picture, the patient's age, how conscious they are, the seizure type, how does that immediately shape your thinking about the urgency and the intensity of the management needed right from the very first minute? It sort of forces you to predict and act based on potential severity almost instantly.
That's a really strong point, thinking about the potential trajectory right from the outset to guide how aggressive you need to be.
Yeah.
Excellent final thought.
Yeah.
Well, that brings us to the end of this deep dive into status epilepticus, all based on your fantastic revision notes. We've covered the definition, causes, risks, presentation, investigations, that crucial management pathway, and the outcomes.
We really hope going through this together has helped cement that high-yield information for you and makes your revision a bit easier.
Absolutely. Keep up the great work with your studies.
Yeah.
And remember, resources specifically designed for this kind of revision, like PassTheMSEO.com and FreeMSRA.com, can be incredibly helpful for testing yourself on topics just like this one.
Definitely check those out if you haven't already. Keep learning, keep revising.
Thanks so much for joining us on the deep dive. We'll catch you on the next one.